actually got the title Indications for VA and VV and ECMO Principles. And what I did is of course, I have some conflicts of interest, as we all have, involved in this ECMO business where the industry plays an important role as well, not only in our daily practice, but also in innovation. But what I did is I split up the talk a little different, since I was asked to provide the first 3 talks. So what I did, I split it in 2 parts. So we'll start with indications and contraindications and ECMO principles for the first half hour, and then we'll go to cannulation for the next half hour. And you're very welcome, and please feel very free to ask any questions, and you can interrupt me at any time. So if you have relevant questions, we can be very interactive if you wish. And then we'll move to the hands-on workshop, which is about cannulation, I think, and I think we could make a good bridge from the last talk, from theory to practice. So this is considered actually the first ECMO in the 70s. ECMO is actually described already in the 60s. This is a patient who suffered multiple trauma, especially chest trauma with an ARDS. And so this is a respiratory indication for ECMO. And you can see here, this is the artificial lung, and you can see that this is really somewhat crowded around the bed, and this is really the original technique, which is coming from the OR and the heart-lung machine, as I will touch on later. So this is really veno-arterial ECMO, and you will learn that veno-arterial ECMO has in the past been the original indication for ECMO, since this was the original ECMO version, and we will come to that in all details. Whereas at this point in time, we consider VA-ECMO a good indication for circulatory and cardiac support, and the respiratory support is usually provided by VV-ECMO. So talking about history, I will tell you a little about my own history, and that starts actually in the University Medical Center in Utrecht, not in Utrecht, but in Maastricht, where I was trained. And probably you recognize situations where we have very sick patients on the ICU, and you have very experienced nurses that are quite considerate about the patient, and everyone is involved. And as you can see here, this patient is on ECMO support and has a balloon pump as well. And this is more than 10 years ago. And I tell you the story just to show you what ECMO was like 10 years ago and what you can achieve with ECMO. This was a 45-year-old male with actually no past medical history. He complained about anginal complaints, and he was catheterized diagnostically. And then the catheterization was complicated by acute, severe, refractory cardiogenic shock in the cath lab, since they produced actually a left main dissection. So then they tried a PCI, which was complicated and not successful, and then they put him on VA-ECMO in a resuscitation setting, and there was no left ventricular ejection fraction anymore, no contractility. So in order to provide a little contractility and pulsatility, they put him on a balloon pump as well. So he was accepted actually in Leuven at that time, so there was a good relation with the hospital in Leuven for a short-term FET and ultimately cardiac transplant. And more than 10 years ago, it was not trivial to transport a patient on ECMO. So what you see here is all efforts were taken to put the patient on transport. The first obstacle is the lift, as you can see here, is the balloon pump, monitoring. So everything is improvised at that time. So we go outside, and you can now see what the transport medium is. It's a helicopter from the Belgian Marine. And the patient was actually lifted with a forklift truck into the helicopter. So you see that the extracorporeal support is actually somewhat a bystander, as you can see here. And we achieved this, and ultimately the patient was successfully transplanted and returned to the hospital as an employee. So that was really a great success for one individual. But you could ask yourself whether this is an ECMO case which is a little over the edge. And I show you this example just to illustrate this is what you are going to experience with ECMO, that you have extreme disasters, but you also will see patients that would otherwise not survive, and they survive with ECMO. And that's also the difficulty with ECMO. And you can argue that this is probably more than 10 years ago, where we might probably not do such things for individual patients at that point in time. That's the question is this really the way we want to spend our money? But if you look to this recent publication, and I'm not very good at Norwegian, but you do not have to. It's a jagerfly, reddet dødssyke patient I Tromsø. So what happened here is there was a lack of ECMO devices in one part of Norway, and they transferred not the patient but the ECMO machine with this F-16 fighter jet to the other part of Norway. So you see that these things happen still today, so enormous costs are spent for individual patients. And I think it is very important to keep in mind what the philosophy of your program would be and could be and should be. So, and we are often facing patients that might have a chance, and we'll come to that in a minute, but you have to spend a lot of effort, money, and manpower for individual patients, and the question comes up if that is reasonable and that is ethical in relation to other patients. So, what is important about modern ECMO, since we come in a very sophisticated technical environment, is that I think you will always find some very enthusiastic medical doctors. But what is actually more important is that you are caring for your nurses. The nurses is actually the most important part, since they will care together with perfusionists. That depends a little on the setup in your hospital and the organization. But the nursing power is really very, very important, since they will stick to the patient 24/7. We as doctors, we are of course involved in many ways, but it's important to create a safe environment, and it's not always so bright and colorful as it is shown here, but it's much more gray, and that does not depend on the device that you choose. This is the Xenios device. You see here very happy patients, but I will show you later that this is, of course, not the reality, but that's what we are striving for. But I think the nursing staff should be trained very well and should be very comfortable. So, and you can see here, it's not really new. So the idea is about how we could manage patients in modern ECMO is really not a new story. So, coming to the details of extracorporeal membrane oxygenation, or extracorporeal life support as we call it today, it's important to realize that of course it is the patient that is interacting with the machine, but in order to understand the principles very well, I would like to focus on the circuit first. So what you see here is that, and that is actually a unifying thing in extracorporeal support with ECMO, that you drain venous blood from the central venous circulation. As you can see here, and it does not matter how you cannulate, VV, VA, VAV, Fabio Taccone will touch on that in the afternoon session. So you start with drainage of central venous blood in every situation. In this way, the patient is peripherally cannulated via the femoral vein and the femoral artery, but the venous blood is drained and it's propelled through a pump. This is in modern ECMO, a centrifugal pump, which is preload and afterload dependent. I'll come to that in a minute. And then the blood is oxygenated in an artificial membrane lung, so which is supplied with a mixture of air and oxygen, and in pediatric ECMO often also CO2. Since this is a very efficient artificial lung, and then it's given back to the patient, and in this situation it's given back to the arterial system. So this is a picture of a veno-arterial ECMO, but it could also be given back to the venous system, that would be veno-venous, or to both the veno and the arterial system, and you will come to that in the afternoon when it comes to veno-arterial ECMO. So the oxygenator is working pretty much the same as the native lung, as you can see here in this comparison. So it's made up of very, very tiny tubes, and it's a very effective system with an active surface of about 1 square meter, depending a little on the size of the oxygenator and the goal that you want to achieve. But if you compare that to the native lung, it is about 70 square meters. So, and what happens here is that through these tubes, the gas mixture is flowing, and it's surrounded by the blood. So there, the gas exchange takes place. And there is, in fact, no possibility that fluid enters the gas tubes. That was a problem in older setups, but in the modern generation, this is really divided strictly. So in there you can see how the gas exchange happens. It's actually pretty much the same as in the native alveolus. So this is how it looks at the bedside. So you can see here the venous blood, which is of course dark, and the arterialized blood is of course light red. And you can see here the tube that is providing the gas mixture, oxygen, air, and in extraordinary situations also CO2, but in adult ECMO this is a combination of O2 and air. And for CO2 removal, you will later see that you could opt for a single O2 gas flow only. So in modern ECMO we do not have roller pumps as has been done in the past and is still done in pediatric ECMO in some setups. The roller pump is an occlusive pump which is still used in the cardiopulmonary bypass system, of course, but the modern ECMO setups are configured with centrifugal pumps. They are not occlusive, so that means if you clamp the circuit, then you will not risk a rupture of the circuit, then the pump will just stop, since the pump is very afterload dependent and the blood will not flow anymore, and the pump will simply stop. What is important to realize is that the engineering of these pumps, and this is a specific pump, a Centrimag design pump from the Toratec, a former Levitronics company. It is provided with a magnet inside, so it can be turned by an electromagnetic motor from the outside. The interesting thing about this specific pump is that there is no bearing. So it's also magnetically levitated, that is the term. So it's kind of hold actually without any bearing within the magnetic field. So it's not in contact with any material, not with any bearing or any other form. So that makes it contactless if it comes to blood trauma. You can imagine that if it's within the magnetic field, not only turned, but it's also levitated, that the blood trauma is minimal and that it cannot warm up as in a bearing. Yeah, is that clear? So this is the clinical situation of another centrifugal pump. This is the Mackay system. the former PLS system. So it's driven electrically, so non-pneumatic, and it's non-pulsatile, so it provides a continuous flow. The centrifugal pump, that depends on the design. If the pump is smaller, the revolutions per minute will be higher, and that depends, of course, on the flow that you would like to achieve. The higher the pump speed, the more blood trauma you create in general. You can achieve flows up to, theoretically, up to 8 or 10 liters, but generally you will achieve 3, 4, 5 liters. And if that is useful, and what the insides and outsides of that discussion of how much flow you should achieve in VA and VV-ECMO and combinations of that, that is a matter of discussion later on. But it's very reliable for weeks. So this is the setup, again, at the bedside. So a lot of components. And you will see that every hospital chooses actually its own circuit. And you can choose for different side ports, but every side port that you have is a risk in terms of air embolism, but also in terms of infection. It can break off simply. So what we tend to do is we keep the circuit as simple and straightforward as possible. So we do not opt for any side ports within the circuit. Here again, schematically, so venous blood is drained through the pump, and then you get an equilibration of O2 and CO2 with the gas mixture that you provide air and oxygen, which is blended here, and is going through the gas tubes. And here you see the membrane, which is a very specific artificial resin that is able to allow gas exchange, but does not allow fluid to exchange. And if you see this, you can imagine that if you increase the gas flow over the membrane, then something happens which is very similar to mechanical ventilation. You just increase the minute volume ventilation, or the tidal volume, if you will. So if the gas flow is increased, then CO2, which dissolves very easily across the membrane, will be exchanged from the blood to the gas. So that is something which is driven especially by the gas flow. Whereas the O2 saturation of the blood is something which is very redundant as well. But if you can imagine that if you want to oxygenate a patient, and you assume that this is happening very redundantly, so you have here a central venous saturation, let's say, of 40, 50, 60, and you assume that this happens here in a good way, then you can imagine that you get here a 100% saturation and a PaO2, which is very high, probably 200, 300, or 400, depending a little on the quality of your oxygenator and the duration that the oxygenator is within the circuit with the patient. So after days and weeks, the quality and the functionality of the oxygenator can deteriorate. But if you assume that the oxygenator also is able to saturate the blood in a good way, which happens, then you can also understand that in order to oxygenate the patient, you just need more blood flow. So the more blood flow you give through the oxygenator, the more well-saturated blood will reach the patient. So then you understand that the CO2 removal part of extracorporeal membrane oxygenation depends on gas flow, but the oxygenation of the patient primarily depends on blood flow. So here you see schematically again the difference between veno-arterial and veno-venous ECMO. So again, central venous blood is drained from the central venous system and reinfused in VV into the central venous system, approximately at the same site. And there you understand that there is already a problem, since if you drain it at the site where you give it back, then you have the risk, of course, that it recirculates. Since if you give it back very close to the site where you drain, then it will go around in the circuit, and you will be not effective in terms of giving oxygenated and CO2 deprived blood to the patient. Yeah, that is very logical, I think. And in VA, you give it back to the arterial system, and you can do it in the femoral artery or also centrally, as we'll see in a second. So coming briefly to the terminology, originally we called the technique extracorporeal membrane oxygenation, since the membrane lung was a very, very important part of the ECMO system. But now we tend to call it extracorporeal life support, and since we have many different techniques now, so the veno-venous, the veno-arterial, but we have also specific forms of veno-venous, for example, that is the CO2 removal technique. And CO2 removal, we'll come back to that in a later talk. You can achieve CO2 removal with relatively low blood flow. So that means 500 milliliters or a liter of blood flow. Then CO2 removal will be still very effective. In veno-arterial ECMO, we have also specific situations where we use VA-ECMO in an urgent situation of refractory resuscitation, and that is called specifically the ECPR, so extracorporeal resuscitation. So respiratory support is veno-venous, and veno-arterial support is circulatory. So again, ECMO is derived from cardiopulmonary bypass, and you can see here the cardiopulmonary bypass is very, very similar to ECMO, but there is, of course, other components as the reservoir, so you can really drain the patient more or less completely. So that is a difference. It's an open system, but the ECMO is, of course, a closed system. So this is central cannulation in veno-arterial ECMO, so the central drainage, and you give it back to the ascending aorta. This is how it looks in the clinics. So, for example, in post-cardiotomy, failure to wean from cardiopulmonary bypass after whatever cardiac surgery. But the easiest, most straightforward and fastest way of cannulating someone for VA-ECMO is, of course, the peripheral cannulation. You can do that by surgical incision and cut down, but also, of course, by percutaneous cannulation, so with Seldinger technique or combined approaches. Important is that you have to realize that the cannulae are very large if you would like to achieve a high flow. And then the problem is that the artery distal to the cannulation site may be more or less closed down. So then you need selective perfusion to the distal leg, and that is tapped off, as you can see here, from the cannula. And that is something which is, in some centers, done standard in every patient in order to avoid leg ischemia, which is a very, very important and an awful complication. And some centers tend to use both groins in order to avoid this, since also the venous cannula is, of course, a large cannula, and the venous compression might exaggerate the problem, and some centers do that only on indication. It's very, it's not trivial, this issue of selective perfusion to the leg, since it is clinically also not trivial to monitor leg ischemia. So if you have questions on that, we can touch on that later on. So veno-venous, again, venous drainage, pump, oxygenator given back to the jugular vein in this case, so femoro-jugular cannulation is the classic veno-venous ECMO cannulation. And you can also opt for another cannulation way that is a single side cannula. So there is a cannula that can drain, double lumen drainage here, so double side drainage and double lumen cannula, where within the same cannula you have two lumina, and you can give back the arterialized blood within the same cannula. So you have a divided lumen within the cannula. The advantage is that the design of the cannula is intended to avoid recirculation, but The exact placement of the cannula, we'll come back to that in the cannulation session, is not trivial. So the question is, what do you need, VA or VV? This is a classical patient, 46-year-old male, acute myocardial infarction. You do not have to be cardiologist to see that the ECG is not okay. This is the catheterization, so left main disease, the section here, revascularized reasonably here, so the LAD is more or less open, the main stem is open, and the CX is open. You can see that the interventional cardiologist has put in a balloon pump. So the balloon pump has been traditionally a very effective way, although we thought it wasn't a very effective way to tackle cardiogenic shock and myocardial infarction. But what we have learned from the intra-aortic balloon pump in myocardial infarction complicated by cardiogenic shock from this study, the IABP Shock 2 trial, is that there is no mortality benefit in this specific scenario. That was the reason that the European guidelines, but also the American guidelines for cardiogenic shock and mechanical support have been adopted from 1C and 3B for all temporary left ventricular assist devices to 3A for the balloon pump for cardiogenic shock and myocardial infarction. But still we stick with a 2BC for all other devices. And then you have the Impella device, the Impella 2.5, which is not such a successful device as you might know from the literature. The tandem heart is not used very frequently anymore. It's also a complicated device where you cannulate the left atrium via the intra-arterial septum, and you pump the blood back retrogradely. It's very crucial that the position of the cannula is perfect, and this has been reported that there has also been some lag ischemia, so that is also out. So you actually only have ECMO, and that is interesting if you see the epidemiology of ECMO in Germany after 2012, so the Shock 2 trial. So there's really an explosion of the case numbers of veno-arterial ECMO after the Shock 2 trial, as you can see here. So this patient is really in refractory cardiogenic shock, requiring short-term mechanical support, ventilation as well, so pulmonary edema. And the quickest way to cannulate this patient is veno-arterial ECMO by bifemoral cannulation. Interesting to see that in the guidelines, these are the older guidelines, not the current guidelines of myocardial revascularization from the European Society of Cardiology, state that if you have done medical therapy, inotropic support, ventilation, balloon pump, reperfusion, and revascularization, and the patient is still unstable, you could already opt for ECMO support in 2010. But I think, in general, we didn't do that widespread. Since it's not so easy to decide which patient will benefit from VA-ECMO. So this is very theoretical. So this is the hemodynamic indication for VA-ECMO. So wedge pressure, systolic blood pressure, mean blood pressure, urine output, metabolic acidosis, and high systemic vascular resistance. But you do not have usually all these parameters in a very acute setting. So you stick with your clinical intuition and with a low blood pressure, and probably you have a blood gas analysis. We have web-based scoring systems as the SAFE score, which is actually based on retrograde data from databases, so it's not prospectively analyzed, which tries to tell you based on different individual patient parameters what would be the survival after veno-arterial ECMO. And you can try this on the web. And if we would have this young patient with no other diagnosis, young, and we put in all his parameters, we would come up in this situation with a 50–60% survival. You will see, if you think that you have a good candidate, this system will tell you that it's a good candidate. But in the difficult candidates that are multimorbid or are somewhat older, then you still have the problem that you then end up with, let's say, 30% survival or 25% survival. And then it's the question, what do you do? And then we come back to this helicopter story. So you should realize for VA-ECMO and acute heart failure, there's no data so far from randomized controlled trials. There are reviews and there are systematic reviews and meta-analysis, and that will tell you that it's reasonable in some patients to think about it. So that was VA. VV. You probably know there has been one randomized controlled trial in modern VV, that is the CESAR trial. You can see after the CESAR trial that the number of cases has enormously grown through the years. But after a while, you can see that in recent years, the number of cases decrease in Germany. Mortality is still relatively high. That also depends on your case selection, of course. But it's interesting to see that there is a tempering of the cases, and you might expect that also in VA, where the mortality is also quite high in Germany, and I think these are very representative data, that you might expect that it will come down again. So VV. VV is intended especially for, and that comes from the CESAR trial, from refractory ARDS, refractory to conventional mechanical ventilation. And the problem is that we still do not know what the right indication is for VV. We in Utrecht use it as a salvage therapy, so if we really see that invasive mechanical ventilation is not sufficient and we see refractory hypoxemia and refractory acidosis, hypercapnia, then we opt for a VA-ECMO in the best of the best patients with mono-organ failure, so no renal failure, no liver failure, no other aspects of multi-organ failure. And then you might expect a benefit. This is the CESAR trial data, 36 to 47%, whereas you have to understand that in the CESAR trial, the patients have been transferred to an ECMO center, but not every patient received ECMO. So it is the comment on CESAR is that it is useful to transfer your patient to a center that has a good ventilation protocol, is capable of doing ECMO. So Veno-venous Femoro-jugular and single-site cannulation, as I told you, but the single-site cannulation is not trivial. You can see that the positioning of the cannula with this infusion port exactly above the tricuspid valve is very, very crucial. So echocardiography is very crucial. And you might choose for this cannula if you go for awake ECMO. But of course, if you have very, very severe ARDS, you will not be able to wake up the patient and walk around with the patient, since VA-ECMO is not powerful enough generally to really support your patient in a sufficient way. This is more intended for patients that are on a waiting list for transplant due to pulmonary fibrosis or terminal lung failure or cystic fibrosis. COPD is also very problematic already, but we use this actually only for cystic fibrosis transfer to transplant. So that has been realized before, as you can see. This is a US-American publication. You can see, you might wonder whether this patient really needs ECMO. If you see this, so this patient might come from a brochure. I can tell you, this is one of our patients, that the days that we, and especially the nurses and the physical therapists, cover these patients, that days are usually very, very gray, very difficult, a lot of respiratory problems still on ECMO. So it's not easy to do this. Mobilization is the reason to do it. And although you're femorally cannulated, you might, some centers even let the patients walk with 2 femoral cannulas over the corridor. We tend to use this device in order to mobilize the patient, since that has been shown to be a major factor of transplant success in lung transplantation. So to mobilize the patient, but this is, and this has been a Dutch television report on one of our patients, who was ultimately successfully transplanted, but you can see here, this is the situation that you're facing. So VA-ECMO combined with Optiflow, and still you have respiratory insufficiency. But you can see that you might be able to manage it. It's 50-50 in our experience, so 50% of the patients that are bridged with awake ECMO will ultimately survive to successful transplantation. Some patients, some people think that ECMO might also be useful in trauma, lung contusion. And I will speed up a little. This was one patient that we had in Maastricht at the time. He fell into the water, so there was freshwater submersion, trauma and lung contusion ARDS. So very complicated case at that time, done with an Avalon cannula. And you can see that this patient survived very well and the lungs cleared up, and that has also been done for traumatic ARDS, even in traumatic brain injury. Some centers in Germany show us, despite of multiple injuries and potential bleeding even, without heparinization, without aspirin for some days, but this is something that you might not try at home in your own hospital. ECMO and trauma is potentially very complex, is my experience, so especially if it comes to chest trauma, traumatic brain injury, drowning, freshwater submersion, and aspiration, hypothermia, cardiac arrest. I think in the Netherlands we never have real hypothermia in these situations as intended in the resuscitation guidelines. We see the patient drown, having circulatory arrest, and then cool down. So it's a hypothermia as a consequence of the circulatory arrest, but it's not the scenario which is intended in the guidelines that you have to warm up the patient with extracorporeal support. It's not the patient that is drunk outside in the winter, cools down, and gets circulatory arrest. This is a totally different scenario. So there has been hypoxia in this situation, cardiac arrest, and you get a very severe refractory instability of respiration and circulation. And you have to realize when you look to the CESAR trial that you cannot base a decision in trauma on any evidence. So there has been just some percent of the patients on ECMO due to trauma. Some patients think that refractory septic shock is a good indication. I don't know. Mechanistically, it's hard to understand that you can probably think of a good survival if you have very severe septic cardiomyopathy, but we've never tried this. This Chinese group says that it's not useful. And you can see that in the Lapitié group, among 200 VA-ECMOs at that time, there have been just 14 patients qualified for refractory septic shock. And I don't know how refractory these patients were. Actually, that is always the discussion, of course. Resuscitation, well, you will see that resuscitation, conventional compared to ECMO resuscitation, over resuscitation time gives better survival, but this is a very interesting paper from 2008 already, but you should be very careful since it's in hospital cardiac arrest. In hospital cardiac arrest, we see that very seldomly. We see cardiorespiratory arrest in hospital. So patients who have pneumonia, respiratory insufficiency, and they will arrest. But a real true cardiac arrest due to acute myocardial infarction is usually not something which you see in the hospital. So in Germany, mobile ECMO has also been done. Then you get these scenarios. The question is if this is really useful. This child did not survive. Of course, time is of the essence. A team in Paris has tried mobile ECMO in resuscitation, but logistics are very, very complex. You can see this here. So mobile team within the ambulance. In the field, as you can see here in the supermarket, on the street, in the railway station, even in the Louvre. And some people find this a little funny. And you see this if these slides come up in presentations on large congresses. So then you will see that the audience will discuss whether this is really a good idea. So I don't know if this is really a good idea. This is Jan Belochlewek in Prague, who has set up a out-of-hospital resuscitation study with ECMO, and he has not yet published the data, but what I understand, and that is something which we understand from all the trials that are ongoing, that survival is not really convincing so far. This is the CHEERS trial, very small group, non-randomized, Stephen Bernard, Australia, 50% survival. After these series, there were some very bad cases, so if they would have taken these cases into account, as I understand from the group, is that survival would have been lower. So it's probably around 25–30% in general. In some regions in Holland, we have 40–45% survival without ECMO. So the question comes up whether ECMO really adds to that. So I would like to conclude that ECMO is really ultimate modern life support, but you should not push it beyond the limits. Thank you very much.